Okay, picking up where I left off on the GI drugs in 47, we're going into the anti-ulcer drugs in Chapter 48, and then that's all we're going to be doing on gastrointestinal drugs. So this one is on the anti-ulcer drugs. This is a picture. Your text goes quite a bit into all the ulcers and formation and all. This is just a really good picture. The ulcerations can be in the gastric, down into the duodenum, and up into the esophagus. There's erosion up in here. There can be a hypersecretion, or for whatever reason, having a lower pH, anything like that, that can cause an ulceration or erosion. Thought this was a good picture, bringing it all together. On your gastric ulcers, common risk factors, the stress H. pylori, which is a bacteria, alcohol and smoking, common treatment, the things you want to teach the people to do, even if they're put on medications, weight loss, small, frequent meals, not eating within a couple hours of bedtime, sitting up after bed, quitting smoking, avoiding alcohol, avoiding foods that are irritating to the stomach. But this is just a good thing on the stress ulcers, physiological stress, shock, Cushing's ulcer, brain injuries, anything that's stressing the body. And a lot of times when this is going on with the patient, they will put them prophylactically on some type of antacid. H. pylori is a bacteria, a gram-negative bacteria that is known to cause the development of peptic ulcers, peptic and gastric and duodenal ulcers. Not all ulcers are caused by H. pylori, but if H. pylori is present, they will ulcerate. They test. Your text doesn't say it, but there's actually a test to do in the stool. The breath test is the easiest thing. If they have it in the office, you have them drink some stuff, and then they blow into this little bag, and it sees if there is urea, and it's 90 to 95% accurate on testing it. The other is checking stool for H. pylori. Your text talks about checking the blood. There is antibodies present. The problem is if they've ever been treated for H. pylori, they will always have those antibodies present in the blood. So if they've never had H. pylori, the blood test is okay, or never been treated for it. If they've ever been treated for it, then you have to do the breath test or the stool. The treatment for it, I just thought this chart, not that you need to memorize it, this is to give you an idea that always treated with more than one antibiotic, at least two. As you can see, it can be up to 4 different antibiotics that are given, along with some type of antacid or a PPI, proton pump inhibitor. You can see this, there's just different combinations that can be done. This is the most effective. To try to get somebody to do this is tough because they have to finish the one, and then they have to start on the clarithromycin and tinidazole. And clarithromycin can be pretty rough on the stomach. A lot also depends on insurance, on what insurance is willing to cover. Metronidazole is in a couple of these. That's pretty common too. You know, if they treat with tetracycline, there's that photosensitivity. Note that there is an herbal alert in your text. St. John's wort may increase the risk of photosensitivity when taken with tetracycline. Okay. So gastroesophageal reflux disease, or GERD, which everybody seems to think they have anymore. It's a reflux esophagitis. It's an inflammation in the esophageal mucosa caused by reflux of the gastric acid contents into the esophagus, Main causes an incompetent lower esophageal sphincter. Some other things, if they have a hiatal hernia, obesity aggravates it. Smoking increases the occurrence of reflux or aggravates the symptoms, makes them worse. I know what the other is. Actually, eating fatty foods decreases your sphincter muscle too. Medical treatment for GERD is similar to treatment of peptic ulcers. It's actually the same treatment. Non-pharmacological measures, which I mentioned earlier. I think wear loose-fitting clothing is the only one I had left out. I thought this was a really good picture. There are 7 categories for treating ulcers. The tranquilizers, anticholinergics, H2 blockers, PPIs or proton pump inhibitors, antacid, prostaglandin analogs, and pepsin inhibitors. And I thought this was good because it shows at which place the different things work, and we're going to break those all down. So with the tranquilizers, which I thought was interesting because I had not seen this used before till I saw the name of the drug, and then I realized I have seen that. Anyway, so I put these first two categories together because the treatment that actually is a combination. This Librax, which is the only brand right now, is a combination of chlordiazepoxide and this clidinium. So the chlordiazepoxide is a type of from Librium. So it tranquilizes, it reduces the vagal stimulation by decreasing the anxiety. Clindamycin bromide, I don't know if you remember that bromide is one of the other endings that you can find with anticholinergics. Inhibits the release of the hydrochloric acid by blocking acetylcholine and the histamine. So this combination can be used usually with peptic ulcers, but again it's anticholinergic, so there's many side effects. And remember the EPS symptoms and all the anticholinergic can't treat, can't be used with glaucoma, and it's contraindicated or category D in pregnancy. So those are the first 2 classes. Now we're to the next class, the antacids. There's multiple antacids. They neutralize the hydrochloric acid and reduce pepsin activity. The 2 that are systemic are the sodium bicarb. I put pictures of things you would recognize. Sodium bicarb is exactly what baking soda is. Still used by many people for ulcers and reflux and the stomach pain. You literally just put it in some water and mix it up and drink it. It was used for many years. You still will find people. So that's one of the things, if somebody has ulcers or chronic stomach pain problems, ask them what they do, because many people do the baking soda, which is sodium bicarbonate. And sodium bicarbonate does become, it is absorbed into the body systemically, so many side effects with this increase or excess sodium, causing hypernatremia or increased sodium, elevated sodium, water retention, metabolic alkalosis because they have too much bicarbonate. And the other thing, even though this used to be used so commonly, they found that doing this, because the bicarbonate is so high, your body has a rebound and actually increases the gastric secretions, the acidic secretions, and makes it actually worse. The other that is sodium bicarbonate is Alka-Seltzer, which has been around forever for the same thing. Tums are calcium carbonate. Lots of people take that. About a third of the drug is systemically absorbed and also can cause an acid rebound. Also can cause hypernatremia calcemia, which the calcium is too high, and it's worse if it's taken with milk products. They can have renal failure and crystalluria, or crystals in the urine. So it can be dangerous. The non-systemic aluminum hydroxide, there's multiple ones that are aluminum hydroxide. I found this picture of Gaviscon. Your text refers to Antiulcer. There's quite a few that are aluminum hydroxide. It's non-systemic, so it's not absorbed systemically. And the other, magnesium hydroxide, I put milk of magnesia up here. That's what that one is magnesium hydroxide. Most people use that when they're constipated, because it's interesting. The aluminum will cause constipation. The magnesium will cause diarrhea. So there's many times that these two, the aluminum hydroxide and magnesium hydroxide, are combined in a lot of antacids, so they equalize each other out so they do not get those problems. Your text gives you plenty of examples in table 48.4 with combinations of the two, like Maalox and Mylanta. Well, those are the most common ones that you will see that are combinations. Gaviscon, it says that it's a combination. No, it's aluminum. Okay, I have it right. I thought for a minute there that I messed that up. Let me see, anything else? Aluminum hydroxide, they have a prototype. It's category C in pregnancy, caution in older adults. There's drug lab food interactions. Drug decreases the effects of tetracycline, phenothiazines, isoniazid, which is a TB drug, phenytoin, which is dilatant for seizures, digitalis, quinidine, and amphetamines may increase the effects of benzodiazepines, and labs can increase the urine pH. Let me see anything else in here. Adverse reactions, hypophosphatemia, which is an elevated anemia phosphate level, osteoporosis, nephrolithiasis, just like with the crystals in the urine. Of course, you'd have increased risk of kidney stones. The next group, histamine 2 blockers or H2 blockers. The antihistamines we've spoken before were H1 blockers. This is different. These are H2 blockers. And common, the cimetidine, which people know as Tagamet, famotidine, which you might know as, famatidine's over here, which you might know as Pepsid. This is ranitidine, which you know as Zantac. Nizatidine is one of the newer ones. It is now over the counter also, and it's called Axid. If you notice again, the DINE are actually TIDINE. Tidine is at the end of all H2 blockers. They reduce the gastric acid by blocking those H2 receptors in the parietal cells in the stomach, promote healing of the ulcer simply by eliminating the cause of the ulcer, which is the acid. Side effects, headaches are pretty common with them. Diarrhea, constipation can be either way with people, but headaches are common. And when you're teaching the patient, reversible impotence and gynecomastia. Gynecomastia is the in the breast tissue. So the next is your PPIs, or your proton pump inhibitors. Reduce the gastric acid by inhibiting the hydrogen. You have a prototype esomeprazole, which you may know as Nexium. It's in your chart 48.3. common side effects of the headache, insomnia, dizziness. Dry mouth is pretty common. Abdominal pain in some people. You put your Zegrid on here, which is your combination. It's the only drug to prevent stress ulcers of critically ill patients. It's a combination of your sodium bicarbonate and omeprazole. Please note your drug interactions where PPIs can enhance the action of digoxin, oral anticoagulants, certain benzodiazepines, and phenytoin because they interfere with liver metabolism. These drugs also, these drugs are 97% protein bound, so any of your protein bound drugs, such as your warfarin, is going to be free and the levels are going to be too high. Your pepsin inhibitors, mucosa-protective, they're non-absorbable. It actually forms a coating. It's in tablets. It can be given up to 4 times a day. It's before meals, 30 minutes before meals, and at bedtime. Some people can't take it that often because the side effect is constipation will be significant. It is the only one that literally covers the ulcer. It doesn't heal the ulcer, it just covers it and protects it while it heals. It's usually given with other medications to promote the healing of the ulcer. And sulforaphate is the only one in this class. Make sure you look at table 48.6 that goes over all of these. The last one is your prostaglandin analog. And if you remember, we just covered in the recent chapters on the prostaglandins that protect mind and protect your stomach, and analog is something that acts like it. So this prostaglandin analog mimics the prostaglandins and does exactly what the prostaglandins does, which inhibits that gastric acid secretion and causes mucus protection in the whole GI tract. This is the newest class of medications. There's only one, misoprostol, or some might know as Cytotec. It is often given when somebody's going to be on a period of high-dose non-steroidals, contraindicated in pregnancy and in childbearing, because it's actually a drug that's used to induce labor or to cause an abortion. You want to make sure you read over all of your nursing processes through several drugs in this chapter. And that's the end of the GI drug chapters.